Sympathomimetic drugs, classification, mechanism, and uses. The emergency room puzzle. Imagine you're the doctor on duty in the emergency department. A young woman suddenly develops severe breathlessness, widespread hives, and her blood pressure crashes moments after receiving an antibiotic. In the next cubicle, a man with septic shock is slipping into profound hypotension despite receiving intravenous fluids. Nearby, a child with acute asthma is struggling to breathe because of severe bronchospasm. And in the labor room, a woman has gone into premature labor at just 30 weeks of pregnancy. 4 different patients, 4 different diseases, yet all can be treated with one class of drugs, the sympathomimetics. How? The answer lies in their actions on adrenergic receptors. Classification by mode of action. The first group is the direct-acting sympathomimetics. These drugs bind directly to adrenergic receptors, just like the body's own catecholamines. Once they bind to alpha or beta receptors, they produce their pharmacological effects immediately. Common examples include epinephrine, norepinephrine, and phenylephrine. The second group is the indirect-acting sympathomimetics. Unlike direct-acting drugs, they do not bind to adrenergic receptors themselves. Instead, they increase endogenous norepinephrine at the synapse. They do this either by displacing stored norepinephrine from nerve terminals, as seen with amphetamines, or by inhibiting norepinephrine reuptake, as occurs with cocaine. The third group is the mixed-acting sympathomimetics. As the name suggests, these drugs use both mechanisms. They bind receptors directly while also releasing stored norepinephrine from sympathetic nerve endings. Important examples are ephedrine and pseudoephedrine. Mechanism of action. Whether direct, indirect, or mixed acting, the final effects of sympathomimetics depend on the receptor stimulated. Let's begin with the alpha-1 receptor. Stimulation of alpha-1 receptors causes vasoconstriction, which increases peripheral vascular resistance and therefore raises blood pressure. This is why alpha-1 agonists are useful in conditions such as hypotension and as nasal decongestants. Next is the alpha-2 receptor. Although alpha-2 receptors are adrenergic receptors, they have an inhibitory role. Their stimulation causes decreased sympathetic outflow from the CNS, leading to reduced release of noradrenaline from sympathetic nerve terminals. This mechanism is clinically important because centrally acting alpha-2 agonists such as clonidine and methyl-dopa lower blood pressure by reducing overall sympathetic activity. Moving on to the beta-1 receptor, stimulation produces increased heart rate and contractility. As a result, the heart pumps more effectively, increasing cardiac output. Drugs acting on beta-1 receptors are therefore useful in situations such as acute heart failure, cardiogenic shock, and severe bradycardia. Stimulation of the beta-2 receptor causes bronchodilation and uterine relaxation. Bronchodilation improves airflow in patients with asthma or COPD, while uterine relaxation can delay premature uterine contractions. Finally, stimulation of the D1 receptor produces renal vasodilation, increasing renal blood flow. This effect is seen with low-dose dopamine, although its routine clinical use has become limited in modern practice. Now let's consider the indirect agents. These drugs do not bind directly to adrenergic receptors. Instead, they increase noradrenaline at the synapse by either enhancing norepinephrine release from nerve terminals or reducing norepinephrine reuptake. The increased concentration of noradrenaline then stimulates adrenergic receptors naturally. The key concept to remember is that, regardless of the initial mechanism, all effects ultimately result from stimulation of alpha, beta, or dopamine receptors. Clinical uses: anaphylaxis, shock, and cardiac arrest. First is anaphylaxis. Here, adrenaline is the drug of choice. By stimulating both alpha and beta receptors, it reverses the three major life-threatening features of anaphylaxis: bronchospasm, vasodilation, and hypotension. This relieves airway obstruction, raises blood pressure, and improves tissue perfusion. Next is septic shock. Noradrenaline is the preferred vasopressor because its potent vasoconstriction restores blood pressure in patients with severe vasodilatory shock. Dopamine may also be used in selected patients because it can improve cardiac output and its effects on renal perfusion are dose dependent, although it is used less frequently today than noradrenaline. Finally, in cardiac arrest, adrenaline is administered during advanced cardiac life support. Its powerful adrenergic actions stimulate the heart to restore spontaneous circulation. Clinical uses: heart failure and hypertension. In acute heart failure, the drug of choice is dobutamine. It is predominantly a beta 1 agonist which increases the force of cardiac contraction, a positive inotropic effect. By improving myocardial contractility, dobutamine increases cardiac output, making it especially useful in patients with acute decompensated heart failure or cardiogenic shock who have poor tissue perfusion. Now let's move to hypertension, specifically central-acting antihypertensive drugs. Clonidine and methyl-dopa work very differently from most sympathomimetics. Although they are adrenergic agonists, they primarily stimulate central alpha-2 receptors in the brainstem. This suppresses sympathetic outflow from the central nervous system, leading to reduced peripheral vascular resistance, a slower heart rate, and ultimately lowering blood pressure. Clinical uses: bronchial asthma and COPD. The drugs most commonly used are salbutamol and terbutaline. Both are selective beta 2 agonists, meaning they predominantly stimulate beta 2 receptors present in bronchial smooth muscle. Activation of these receptors produces bronchodilation, rapidly relieving bronchospasm and improving airflow in patients with asthma and COPD. They are usually administered by inhalation, allowing a rapid onset of action with fewer systemic adverse effects. Clinical uses: nasal congestion, premature labor, and bladder. First, as nasal decongestants. Phenylephrine and pseudoephedrine act mainly as alpha-1 agonists. They produce nasal mucosal vasoconstriction, which reduces mucosal edema and congestion, allowing easier nasal breathing. Next is tocolysis. Terbutaline, a beta 2 agonist, relaxes uterine smooth muscle through beta 2 stimulation, helping delay preterm labor. Finally, in overactive bladder, mirabegron is a selective beta 3 agonist. By relaxing the detrusor muscle, it increases bladder capacity and reduces urinary urgency and frequency, making it an effective alternative to antimuscarinic drugs. Clinical uses: central nervous system disorders. A classic example is amphetamine, an indirect acting agent. It works by increasing the release of noradrenaline and dopamine from central synapses, thereby enhancing endogenous neurotransmitter activity. Clinically, it is used in ADHD, where it improves attention and concentration, helping patients maintain focus and reduce impulsive behavior. It is also useful in narcolepsy, a disorder characterized by excessive daytime sleepiness, because it promotes wakefulness by stimulating the central nervous system. Drug summary: Sympathomimetics at a glance. Let's quickly revise the clinical uses of sympathomimetic drugs with this summary slide. For anaphylaxis and cardiac arrest, remember adrenaline. In acute heart failure, the key drug is dobutamine. For hypertension, think of clonidine and methyl-dopa. In bronchial asthma and COPD, the commonly used beta-2 agonists are salbutamol and terbutaline. For nasal decongestants, remember phenylephrine and pseudoephedrine. In premature labor, terbutaline is used for tocolysis. For overactive bladder, the selective beta-3 agonist is mirabegron. Finally, in ADHD and narcolepsy, the important indirect-acting sympathomimetic is amphetamine.